I'm going to begin by saying we're at the annual meeting of the North American Menopause Society, and I am speaking with...
Dr. Deborah Rhodes.
And you are?
I am a professor of medicine at the Mayo Clinic in Rochester, Minnesota.
Well, we've heard of that place. Most people have. And you were part of a session that was in total was awesome. You were particularly awesome, and you talked about the challenges and the novel new things that are out there for breast imaging in women with dense breasts. And I wonder if you could tell us a little bit about it.
Well, I can. I think our team at Mayo Clinic had the audacity to think that we might be able to develop something to overcome the limitations of mammography in the dense breasts.
Mm-hmm.
And I came to this issue as a clinician. I practice in a breast clinic at Mayo Clinic. I'm an internist by training, and we have a multi-specialty breast clinic where we see women with all kinds of breast issues, ranging from breast pain to screening abnormalities to benign breast disease, all the way to breast cancer. And in my practice, I was seeing women who had very dense breast tissue, and they were often traveling long distances to come to our institution for their screening, and they would have a screening mammogram, and I would say to them, good news, your mammogram looks normal. But in my heart, I knew that we were very unlikely to see a tumor if one was present.
What makes those dense breasts so problematic for the radiologist?
So breast density is truly like the wolf in sheep's clothing. A dense breast appears white on a mammogram, but so does a tumor. So a tumor that's in an area of dense tissue will be obscured because you cannot distinguish it from the background dense white tissue.
So it just blends in, you can't see.
It blends in. And so I felt that I was really giving false reassurance that, yes, the mammogram didn't look abnormal, but I didn't have a high degree of confidence that it would if a tumor were present. So through a series of some chance meetings with some scientists at Mayo, we began work on developing a completely different way of looking at the breast tissue. So mammography relies on X-rays, and X-rays cannot distinguish between tumors and dense tissue, but other forms of radiation can. And so we began developing an imaging modality that relies on gamma rays, not X-rays. And gamma rays are not impacted by the density of the surrounding tissue. So a tumor is very apparent even in a dense breast using a gamma detector. So we developed a new type of imaging device relying on gamma detectors rather than X-ray detectors. And we have been working on this now for over 15 years. We've done a number of large studies, all funded by the Komen Foundation. So all funded by essentially women who are passionate about breast cancer survival.
Yeah, of course.
And we have found in these studies that molecular breast imaging, the name of our technology that is now licensed to several imaging companies, but for which I do not receive any royalties, molecular breast imaging detects 3 to 4 times more cancers in the dense breast than mammography does.
How does it work? What do you do exactly? You take a shot? Tell us how it would go about it.
Well, probably the biggest downside is that it does require an injection, and of course many of us are a little squeamish about that. But having myself just had my annual mammogram, I can tell you very honestly that I would rather have a very brief injection than a mammogram with 40 pounds per square inch of force applied to my breast.
In other words, they don't have to squish you so much.
They don't really squish at all. Very gentle compression is applied just to keep the breast still, but it's certainly not a painful test. It does take longer to complete than a mammogram. So I think that there are advantages and disadvantages for both of these tests, but to me, the most compelling aspect is the fact that it's detecting 3 to 4 times more tumors, and of course, that's the reason why you're screening for breast cancer anyway. So in my opinion, we ought to be using the test that's most likely to detect the cancers.
Now, is this available everywhere?
No, it's not, and it's been slow to gain adoption, mainly because mammography has been the gold standard, the one-size-fits-all approach for breast cancer screening since breast cancer screening began. And although mammography has evolved, we've gone to digital mammography, and now there's this 3D tomosynthesis mammography. At the end of the day, it remains an X-ray of the breast, which is always going to be problematic if you have dense breasts.
And if you have this procedure done, it takes a little longer. How much radiation do you get with this versus a regular mammogram?
It is more radiation. It's about twice the amount of radiation, but it's still within this category of very low-dose imaging tests, for which radiation safety organizations in this country and around the world have said that tests associated with these low levels of radiation have no known biologic risk associated with them. And it's really only when you get up to very high doses of radiation, which can accrue if you do a series of different imaging tests at the same time, that you begin to see any biologic risk.
And are gamma rays safer than X-rays?
So that's an interesting question, and I've acquired a sort of baptism by fire education in radiation risk through my research in molecular breast imaging. Interestingly, in medical school and residency, I never received any training whatsoever on radiation risk. And so I really had a lot of misconceptions about it, and frankly, I think most doctors do, and certainly most patients as well, mainly because we have been indoctrinated with this idea that any amount of radiation exposure is risky and we should do whatever it takes to avoid it. But it turns out that that's just simply not true, because the body is beautifully designed to encounter low doses of radiation, and in fact we do every day. Living on planet Earth exposes us to radiation from our environment. Taking a flight exposes us to radiation. And yet, for some reason, people feel like imaging tests are this special, dangerous kind of radiation, and they're not, as long as they remain in this low-dose range. So I've really come to understand that choosing the best test should not be about whether there's a little bit more radiation. It should be about whether that test succeeds in the purpose of doing the test in the first place.
Final question, that is, since it's more sensitive in that you can see better, can you do them less often?
That's a great question, and I wish that we had been able to study that question. We are going to address that question in a study that just began in July and will take 3 years to complete. It's the first time that we've ever examined serial molecular breast imaging to look at whether it would be possible to alternate mammography with molecular breast imaging every other year instead of doubling up on them, which of course doesn't make sense from the standpoint of time and cost. And my personal view, although we haven't proven this, is that it probably would be perfectly adequate to alternate these every other year, because molecular breast imaging is eliminating that reservoir of cancers obscured by mammography in the dense breast.
Thank you very much.
You're welcome.